Just so you know, this is not a flak jacket. I'm not that scared of you. And secondly, it's also not a back brace. It's a cooling vest to give me a good chance of my autonomic system coping with the heat, because, of course, the healthy response to heat is vasodilation, which is great. My body is very good at that. However, my veins are already a little bit too floppy because of the EDS stuff, bendiness, I call it. So the added heat then makes me really drunk. Or stroke-like symptoms, but people tend to panic when I say that. Drunk tends to make them laugh, and I'm much more comfortable with someone who chuckles and go, okay, I'm aware of that. So welcome to living well with an HMS. So the contents is a brief about me, how hypermobility affects me, a bit about management, exercise and pacing, all from the perspective of a patient who is admittedly a little bit physio-obsessed and probably an expert patient. And a bit about communicating with medical professionals, because this is much harder than you might think. So, my name is Hannah Ensor. I actually have a first-class degree in environmental health, worked as an EHO for a couple of years and got medically retired because I was too drunk to function, basically. I am hypermobile and I have POTS. I run Stickman Communications and I'm apparently a leader in patient communications, patron for kids and teens for the HMSA and also their hypermobility spectrum disorders ambassador. I've worked with various other charities across the UK as well, and apparently I'm influential. So, hypermobility, my battery just fell out. Hypermobility and how it affects me. I'm a contemporary dancer. Well, hypermobility is great. That's what happens to me after I've done it, after I completed the dance. For me, this isn't good day, bad day. This is a combination of constructive management and recognition that actually putting my arms above my head always triggers POTS. And the postural changes involved in dance also mess with POTS. And the best thing I can do is go, right, I'm going to feel awful after this, but if I go crash out, don't even try and talk or sit or move for about half an hour, that then gives me a really good boost towards getting me back onto normal. And then I can gradually start getting up about and functioning again, instead of push, 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 land in hospital for 5 weeks, which I've also done. Not wise. So yeah, be very, very, very wary of saying push through it to anyone who's hypermobile. The chances are it's going to crash. So my symptoms, loads of them. I'm just going to talk about a couple. Now the important thing to recognise is if, like me, your patient was born hypermobile, comes from a bendy family, and has lived with this normal all their life, I'm not going to list all these as problems because I don't know they are. I was in my mid-teens when I worked out what heartburn was. Because, heartburn, it must be really, really, feel like a heart attack because that's what everyone says. And I'm like, well, it doesn't. What I get is it's quite clearly the acid from my stomach coming back up. So it didn't occur to me that this was actually a thing rather than just what everyone experienced. Poor proprioception is another one I've done this on. I was convinced until well after diagnosis, which happened when I was 24. I was already a wheelchair user by that point. Until that point, everything was psychosomatic. And I got diagnosed with EDS. They went, oh, this was after I'd collapsed at work with severe POTS. They thought I'd had a stroke. That's how bad the symptoms had got. So I had slight face drop, facial numbness, couldn't string a sentence together, got my words wrong. It was all just POTS and I'd been ignoring the symptoms for ages, so they'd escalated and I'd fallen on the floor. Because I don't faint, I just get really, really drunk. So I got diagnosed with the joint problem. They said, but instead of becoming depressed about the joint problem, all this extra stuff, your drunkenness, that's psychosomatic instead. So instead of becoming depressed, you've created these symptoms. So then they were going to hospitalise me in a psychiatric setting to try and help me with the POTS symptoms. I then got diagnosed with POTS and was like, okay, I have no unexplained symptoms, and then I get the pre-admission assessment and I'm like, terrifying. Anyway, fortunately, the therapist had a sense of humour. I wheeled in, got out of my wheelchair straight away, sat in the chair and went, hope you don't mind me doing this. I don't use my wheelchair when I don't need it. And it was like, this is unexpected, because it wasn't what they were expecting. But that took me going, how can I rattle their cages early enough so they don't get so fixed on, we know it's psych, that I'm then channeled down that route anyway. So fortunately, then I saw the final assessor who went, who referred you? Great. So I have a letter saying I'm sane. Anyway, back to poor proprioception. That was a digression. I was convinced my proprioception was fine until several years after diagnosis. And I figured out that it was probably a little bit off, because that was one of the things that come with hypermobility. So it's probably a bit off. And I said to a colleague, non-bendy, I said, oh, you know that thing when, did you ever play that game as a kid? When you've been sent to bed and you're supposed to be asleep and you're not tired yet. So then you relax and forget where your legs are, and then move and see if you got it right. And they looked at me like I was an alien. I'm like, is this not normal? Apparently not. I remember a paediatrician checking my proprioception, and he said it was fine. I now have realised it was fine, because he got me to shut my eyes and move my leg and said, what position is your leg in? And I went, okay, I can feel a bit of the skin fold, so that bit feels like it's in that position. The gravityness affecting my hip feels like it's in that position. The, what else do I use? Slight bit of muscle tension, oh yeah, that feels like it's about that position. The reality is going to be about in the middle, so I say, oh, it's about there, and that was about right. But it wasn't an automatic instinct, it was a logical process. But for me, that's second nature, because that's how you know where your legs are. So you either look at them or compression. So you'll often see me, especially as I get tired, towards the end of the day probably, I'll sit on my feet, because then my brain doesn't need to work out where my feet are, because I know. And also helps with POTS, of course. I have both unstable joints and hypermobile joints, so it's not just about bending impressively, it's the wobble that can cause the problems. Pain. Now there's chronic pain, there's injury pain, and there's subluxation pain. And for me, learning to differentiate between the three has been absolutely key. What do I mean? I mean, the chronic pain is what I call grumbly joints. You know, it's there, joints talking to me, it's like, yeah, remember, I get irritated, and it's like, yeah, I know. So yeah, I have to respect it, but I don't take that much notice of it, to be honest, until it starts escalating, and then I'm like, okay, pacing, I'll change position. Injury pain, I have a completely different approach. It's like, right, okay, that feels like I've actually done something, so I might brace or splint it for like half an hour or maybe a day, and then I'll be light duties, make sure I keep it active, have extra concentration on muscle use, and then be aware that it might take, if the doctor says 3 weeks, it will take me 6 weeks. Not a big issue, but once I'm aware of that, I can actually let it heal properly before I return to full duties. Subluxation, completely different strategies again. If I'm like, okay, that feels wrong, or it hurts when I put pressure on it, but not when I don't, which for me means there's something that's not in the right place. The answer is quite simply, get it back in place before you put weight on it again. Because of course, like for example with my wrists, they come out all the time. By out, I mean the little bones go places, don't know exactly what they do, but it means that suddenly I might have restricted movement, or I'll lean on the wrist and it goes, there's Ferrari playing 0 to 60 and then back again in a very short space of time. But all I need to do is this. So if you see me doing this, I'm probably relocating my bones. If it's bad, then I'll get someone else to give me a handshake and then pull back, and then it pops delightfully back into place, and I can go straight back to normal. Because I haven't necessarily injured or stretched anything, because I am that bendy. It can go out and it can come back in. If I've used it, the chances are I'm going to have injury as well. So once it's back in, I need to go into the injury route. So, and for my sacroiliac joints, using a wheelchair has been a great pacing tool because it's meant that I've been able to go, oh, they're out. Try various stretches to get them to realign. If it's not worked yet, sit back down again. I can still get on with my life. And then try again with the stretches later and just repeat that until it's settled. So if you're going on a pain management course, if it's a standard one and it's about pain doesn't mean injury, it takes quite a bolshy patient to go, right, I accept that pain doesn't always mean injury, but if it does mean injury this time, then I'll treat it like an injury. I'm not going to panic, but I'm going to treat it like an injury. But if you've got a very strong ethos in the pain management course about it's chronic pain, be aware that in a hypermobile person, there need to be some of your pain is chronic pain, and over time, see if you can help them to learn which bits are which. Yes, everything else is pretty self-explanatory to a degree. These might not all be specific to my hypermobility syndrome. Some of them might be caused by other things. I don't really know, and to a degree, I don't really care. They're all part of my normal, and therefore any management techniques have to take all this into account. So, yeah, the hypermobility has its advantages. Don't tell your patient first off that, oh, you would make a great dancer, because it tends to be taken really offensive. So for me, it's taken years to build up to this point. So pre-diagnosis, I kept on getting advice to rest the joints and to ignore the pain and to basically everything inappropriate. Whereas what I wish I'd been taught was respect it, but don't fear it. So yes, I'm hypermobile. I need to take this into account with making sure I keep strong, making sure I don't do flop positions for long periods. Or if I'm having a floppy day, I need to make sure that all my joints are resting within my normal range. I don't really care what other people's normal range is, because I can rest in positions quite comfortably that most people couldn't ever reach. But the important thing is not at the end of my range, because if I rest at the end of my range, I can get loads of problems. So, just out of interest, has anyone from watching me formed any sort of general do I look hypermobile-ness going on? So is the general impression that, I'm quite hypermobile, really? And then if I, things like this, again, it's all completely normal, comfortable stuff. Right, now, onto the baiting, which we all did earlier. I think 90% of you are more flexible than I am. I score, anyone want to guess? 1. How many of you expected that? So, I will run you through my score. I can do in fact, I'll do it because I need a wiggle. So I can do that one. No problem at all. Bit careful with the standing up again. Did that too quickly. Right, then we have the elbows. Totally not hypermobile, would you agree? This is where you have to be very canny, because I have a lot of elbow problems. They will lock, and I can't sleep with them resting straight, because I pull the ligaments, and then I end up jamming them. And the sensation of the smoothness of the humerus when it comes forwards is highly unpleasant, and one that says don't force anything because this could go very wrong. So they're not hypermobile, but I'm only doing this once, so look carefully. I have a lot of sideways movements. My knees are the same. That's not hypermobile. But they wobble sideways, and I can rotate my shins quite a lot without moving my knee at all. So, and same with The thumb to wrist I could actually do for about a week as a child, because someone in my class did it. I didn't know I was hypermobile. I thought I was average. They did it, and I thought, oh, that's interesting. I tried it a couple of times, and every time I tried it, I could go further. So after a week of doing it, say once or twice a day, I could touch my thumbs to my wrist, and then I was like, hang on, but that's starting to feel my thumbs are a bit wrong, so that was a bad idea. Let's not do it again. And then I noticed that some people's thumbs pop inwards. Mine do that. And then I thought, well, that kind of hurts when it does that, and if I'm holding something. So I used to sit in assemblies and practice moving my thumbs without without popping them in. So I think some of my lack of the baton is actually instinctive coping mechanisms, like never resting my elbows at straight, never resting my knees so they're resting on the ligaments. Because I'm definitely hypermobile. But this is one of the reasons why it was all psychosomatic until I was 24. Every doctor who's ever done the Baton score on me diagnosed me psychosomatic. In fact, even post-diagnosis, more recently, I saw someone who knew an awful lot about hypermobility, and he proceeded to tell me I didn't have it. I also didn't have POTS. I shouldn't be on any POTS medications that I was on then. All treatment should be withdrawn, and I shouldn't be given any physiotherapy. And I was like, well, you're a twit. Fortunately, by that stage, I was already very confident self-management, so I went directly to the physiotherapy department and said, hi, can I come back, please? And they said, yes. So again, I made progress. So yeah, don't be surprised if your patient's got some hang-ups about things doctors do and say, because there is some questionable wisdom happening out there at the moment. Again, my little fingers don't really go back that far, but I'm not going to force it. If I wanted to, I could probably score a 9 if I practiced for like a couple of weeks. But to me, that's like self-harm, so let's not. So yes, technically, under the new criteria, I'm a bit of a conundrum, because you can only boost up with the alternative score if you have at some point scored the 6 or whatever it is, or at least scored 5, then you can be bumped up 1. So because I score 1, technically I'd be localized hypermobility spectrum disorder, affected in every joint. So, with what the physician decides to diagnose me with, if anyone wants to play at diagnosing me later, that's absolutely fine. But the important thing is that whether it's EDS, whether it's hypermobility spectrum disorder, it's you treat the symptoms and be aware that hypermobility might be affecting things. Yes, so if you've done the scale and you're still thinking maybe, just get a feel of what the joints are doing. And also, Philip Bull mentioned the handshake. If I do a relaxed handshake, squishy hand. But if I'm in, greeting people, you'll get a very firm handshake because I have very strong hands. And then I'll mask the hypermobility so you won't feel it. So be aware of all these unconscious coping mechanisms that an active hypermobile person might employ. And it's not even, I didn't realise about the handshake thing until last night. It's like, oh, well, yeah, if anyone's trying to recognise mine by my handshake, they won't, because I'll be in keep my hand attached mode. So, management. Injury happens when the forces exerted on the tissue exceed the current strength of the tissue. Correct me if I'm wrong. This is based on a patient management talk I do. The weaker collagen means injuries are more likely, but there are things that help. Reducing the forces down to a level you can cope with, and then strengthening the tissue so it can cope with more. For me, that initial reduction was important because I was like, well, I was really active. I used to play rugby. Interestingly, I never got injured on the rugby field because every time I tackled everyone, I was in what I call ballet mode, which is when physical awareness of every muscle tension, and so I'd hit someone with an acute consciousness of my muscles in my shoulders and my back and my legs all being activated. Then I'd injure myself, like dislocate my shoulder in an art lesson because I put my hand up and was like bored. So it's amazing how much difference that muscle tone can make. So for me, initially I got medically retired. Horrible at the time, best thing I could have done, because it meant I could then take my activities levels right back, and the demands I was putting on myself in terms of concentration, in terms of sitting still, in terms of driving long distances, all that kind of stuff that was putting a strain but not building much muscle. I could stop with all that and then find out what I was capable of and build on it. That's a common mistake patients make with pacing, thinking if I have to pace down, that's it forever. And actually, no, it's a pace down, build strong. Injury recovery is often slow, but it can also be complete. The trick is to let it heal before you then put as much strain on it as you would a healthy thing. So I'm actually one of 10, I have 10 siblings. So we're all hypermobile again, which is why it took me so long to be diagnosed, because next to my siblings, I'm just a little bit bendy. But then you put my siblings next to anyone else, and they're quite bendy. So now all my siblings know if they get a sprain, it's going to take a bit longer. So it's almost like my diagnosis is now enables management of all my asymptomatic siblings, because they all know that, I'm getting a bit of random hip pain. Yes, Hannah, I'll do some exercise. Because it's not about medicalising it, it's about normalising it. The family is bendy. We now know this. The family will heal slowly. We know this. Now we can use that information. Ironically, I think I was actually diagnosed by a paediatrician when I was about 11, but we weren't told, because at one of my appointments, they commented, so I'd improved from a really bad flare-up in my, just when I hit puberty. And I learned to ignore some of the pain and just kind of get on with life. So they then commented, oh, are you still doing your 20-minute cycling a day? And I was like, well, no. So, we should do that forever. And of course, I just went, well, no one else does. So quite frankly, you're talking nonsense. I didn't say that, but I cycled to school, but I didn't cycle in the holidays. But now, looking back, I'm thinking, they knew I was hypermobile. That was good advice to a hypermobile person. But if you haven't said, you are a little bit different to average, you just need extra coping mechanisms and life will be fine. If they'd have said that, I'd have carried on cycling and been more joint position aware. But because we were told there was nothing wrong with me, why then should I employ the sensible coping mechanisms? Why should I take extra care of my joints if there's nothing going on? So my management involves braces or splints with caution. So if I've just dislocated my wrist, I'll put it back in again. If it comes out 3 times in an hour, then I will brace it for maybe half an hour, maybe an hour. Just it's almost like it lets the muscles relax and remember where normal is. And then I'll take it off and light duties. Or I'll wear splints when I'm doing something extra. So if I'm going to walk extra distance, or I'll wear knee braces. Or when I moved house, I wore my wrist braces a lot because I was packing things in boxes. And it was like, well, I have a choice of either getting someone else to do it all, or I do what I can and brace up for it. And to me, if it's something that's gonna make your wrist fall off, then why not brace? So you're still getting some benefit from the activity, but then take them off whenever you can. It scares me when I see hypermobile people covered in braces and sitting in a wheelchair, because, some people will need it, but the majority of people, braces should very much be an on and off thing. And incidentally, you as professionals can really help with that especially if you've got a bendy in a wheelchair. So I'm a bendy in a wheelchair who just crawled across the stage because it takes too much concentration and Pots symptoms to try and walk across, and I needed to save my speech. So, but a lot of people are like, oh, well, people will judge me if I get out of the wheelchair. But if you as a professional have said, make it very clear to them that, yes, use it for pacing, but get out of it. And sometimes even give them a letter saying, occasional use of wheelchair or mobility aids, then that gives them license to go against public expectation of wheelchair equals paralysis or you're a faker. And then that can actually help them have the confidence to then start to manage rather than just avoid symptoms. Does that make sense? This is just my thoughts as a patient who's also seen many other patients and has patients whinging to me all their concerns. Being postural aware has been really important for me. It's not because there is a perfect posture. I've had a few debates with physiotherapists about this because they said, oh no, posture's not important. And I'm like, have you seen what I do when I relax? If I let myself flop, I cause myself pain. It's as simple as that. But if I'm postural aware, I build the postural muscles, I get stronger and stronger, and since taking a posture approach, my symptoms have really improved. So it's not finding a perfect posture, it's recognising what range I have control over and making sure that I live within that range. And over time, that range can expand. So dance for me has been a great way of expanding that safe range so I can hold all sorts of really good positions. But it's safe for me. It wasn't 5-10 years ago, but it is now. And respecting the warning signals that my body is struggling. It was actually a physio who taught me this. It was one time I pushed way too far because, again, I didn't really believe that hypermobility syndrome was real or that POTS was real. I thought my POTS was mild and my heart rate was hitting 180 every time I stood up. Probably wasn't mild. So then the physio I was doing walking practice on the ward, and I walked 2 meters, and then my left knee was going. And left-sided weakness for me is one of my POTS symptoms because it's lack of blood flow to the brain. On a temporary basis, I assure you, it's not permanent. I don't have much brain damage, I don't think. So then the physio was like, your knee's going, sit down. It's like, no, I can do more. It's like, no, sit down. Your body is not benefiting from you flopping along. The body benefits from me being in control and actually using the muscles. So then a couple of sessions like that, when the physio was like, no, you can't actually cope with physio now, was a real light bulb moment, because it was like, oh, so I do need to be listening to what my body's saying and recognising that my body has useful things to say. And when I started listening to when the knee said stop, so during that session, I wasn't allowed to ever carry on walking after my knee had started going. Every day, I could walk further. It was like, wow. My body is responding to this, me listening to it. So that was really useful. If you're going to ask why someone's in a wheelchair, please don't ask them, why are you in a wheelchair? This is because they're probably really touchy about it and feel guilty that they're in a wheelchair. A combination of also feeling it helps them and feeling that professionals will just shout at them and get cross. So why are you in a wheelchair? The answer will probably be, because I need it, duh, I'm not in it for fun, which isn't really very constructive and kind of creates a bit of hostility. They might not say it, but that's what 90% of people I see on our support groups, that's the mindset. But if you ask them what symptoms does your wheelchair help with, what situations do you use your wheelchair in, then this opens up for much more constructive discussion. You can get a feel for whether the patient's using it sensibly. I'd like to think I use my wheelchair sensibly, though I have gone into an appointment with someone I haven't seen before, and I get the not being afraid of movement lecture, and I'm sat there going, I'm a contemporary dancer. Afraid of movement really doesn't apply. So just be aware of how you phrase it. Incidentally, I use my wheelchair because of the relationship between having very hypermobile spine, hips, knee, and unstable, so you've got the sideways wobble, and there aren't muscles to control the sideways wobble of knees. So my knees and then my feet and my ankles are also very hypermobile. So I have to consciously, almost like tightrope walking, consciously be aware of exactly how I put pressure, how I walk. And everything has to be perfectly in a line, which is fine. On a good day, I can do that for like maybe even 20 meters. However, the POTS means that the longer I'm upright, the less coordinated I get as I get this reduction in blood flow to the brain. So effectively, it's like trying to tightrope walk while getting increasingly drunk. And whereas one of the management techniques for POTS is if you walk around lots, go on a jog, because that's even a slight reduction in my coordination has a big effect on my walking because so much control is required. I can't do that push through stage because all that happens is I hit the deck or start staggering like a drunk string puppet with my legs going all over the place because you've got the proprioception, you've got every single joint needing conscious muscle control because there is no ligaments that's going to make it do the right thing in default. So for me, it's very much a control. It lets me do my job, lets me function, lets me get out and about, but I'm not glued to it. I use it as an enhancer and a pacing tool. So yeah, I hate seeing other bendies in wheelchairs until I get to know them, and then then I'll decide whether I really don't like it or whether it's okay for them. Sounds kind of hypocritical, but I know how hard I work to keep myself as functioning as possible. And I know that I've never stayed in it because I'm afraid of what someone's going to say. I tend to find that a big smile will turn away any, hello, oh, okay. And clearly you're confident. Well, must be a reason for that then. I'll leave you alone. Pacing. Often, especially for newly diagnosed people, pacing is when you've crashed out, you then have to stop. And it took me like this physio in the hospital's lessons to teach me that actually the earlier you change activity, the better. Then you get more done. It's not about doing less, it's about doing smart. So this is actually from one of my leaflets, which is on pacing, written from a patient's perspective. And the things, not teaching pacing, but reminders, like swap, don't stop. Concentrating can be a challenging thing, so pace with that. So I'll make sure I have my 30-minute timer when I'm on the computer. And then I get up and move around. And on days I have my 30-minute timer, I get so much more done for so much less symptoms, even though it feels counterintuitive. But I'm in the middle of this, I'm on a roll. The alarm's gone, get up. What is exercise? This is a really important one. I'm aware I've overrun a bit, but I'll shut up if you want me to. Okay. What is exercise? The average patient, it's your physio exercises and it's your running around madly doing athleticness. Now, when I was first diagnosed, I know the doctor was saying you need to exercise more. I'm like, as I went downhill, I was exercising. I was playing volleyball every week. I was walking around and doing stuff. I had a job that involved being up and down stairs and in and out of people's houses all day. I was exercising. I was fit and healthy. And I'm going down while exercising. And then doctors are telling me to exercise. It's really confusing. And it sounds like the doctor or the medical profession is talking nonsense. Because my experience says exercise not caused this, but if exercise was the cure, I wouldn't be hurting. So I then went through a phase, bearing in mind I also had severe POTS, so fatigue was a massive issue. Of, well, I do the housework, that's exercise. And then it kind of slowly dawned on me that what I call flop mode or zombie mode housework benefits me nothing other than a clean house. But if I do controlled, aware of my posture, making sure I'm using my muscles, then housework can be exercise because I'm actively using muscles. Whereas it's amazing how much you can get away with not using muscles at all, especially if you're hypermobile. and you can use the wrong muscles, and you can, instead of putting your arm out, go like that, because then you don't have to use your arm muscles. But actually, if you set the shoulder, I stopped having wrist dislocations while making a cup of tea overnight, because I realised that if I've been watching, it must have been the 2012 Olympics, I'm watching the gymnastics, and I suddenly realised that they do this thing before they, take a run up. And I was like, oh, I wonder what would happen if I do that before I make a cup of tea. So I literally stand there, set my shoulders back, wake up my fingers, good strong position. Great, no dislocations. Whereas before, I'd kind of go like that, and of course the sideways pressure on the wrists, the shoulders, and it would always hurt. So it's amazing how much just you can use housework as really good physio, provided it's got that muscle usage in it. So yeah, I moved on from the flop to, there you go, see me, me making my cup of tea, recognising that again, this is an exercise, but if I can manage to sit up, even if it's just for 30 seconds every time there's adverts on the telly, that's a bit of exercise, and building it into my routine is a huge help. As a physio tip, kind of wondering how long I can get away with talking, all these things I'd love you to know. As a physio tip, I had a few exercises to do in standing. Now, because I've got very strong core muscles, but I've also got hypermobile spine, hips, knees, ankles, feet. So if I'm in standing, I'm having to work all those muscles, and it's kind of overload. And I wasn't really making any progress, because I'm guessing I'd get one bit right, and then the next bit would be in flop. So what then my physio suggested was, right, do it in kneeling. And so, chucking the ball to each other in kneeling, and then leaning different ways. So then I started doing dance in kneeling. So I've got a pair of knee pads. And I really started to then build up my hip and this bit muscles. So then what I'm hoping is over time, I will then be able to move on to doing some more stuff in standing, because I don't have to concentrate so much on this bit, because it's more built into the muscle memory, and I've built up enough strength for it to cope with it. So again, don't be afraid to adjust the exercises to, okay, let's focus on one bit at a time and take the pressure off the rest of the person. So that obviously you can't only do core, because everywhere needs exercise, but just being aware of some of the tricks and tips. Now this one will be very quick, because you've got some of my leaflets in your delegate packs. Patients tend to start off with, they know what hypermobility syndrome is. Oh, yes. It's amazing. It's not actually constructive. And then also, this then means that you then get, the moment you give an inappropriate advice, by that mean I don't mean you get it wrong. I mean, you say to someone, try this, and it doesn't work. The illusion that you are God is shattered. And so what I tell patients is that you're not, every doctor and professional who's helped me has made mistakes. What it's about is communicating the effect of whatever's been prescribed, and then working with that. And when a doctor says, do this, they don't actually mean, do this religiously or you are a failure. They mean, try this, see how it affects you, tweak it, come back and we'll discuss how it's going. At least I hope you do. If you don't mean that, then please do from now on. So yes, you're looking for a partnership, which I heard someone mention in the comments earlier, and I thought, yes. So basically, it's medics have some useful information, and I will see what I can use from their advice, but ultimately, I have to manage my condition. And a classic example of this was my very excellent cardiologist in Bristol. He's the one who got me up and talking. Whether you're glad for that is another matter. So he got me on some great POTS medications, which brought my symptoms so I could then cope with eating and talking, which then meant I could cope with a little bit of exercise, which has then meant I've now built to a point where I have no meds at all for POTS. But anyway, he found this great regime they use to rehab the people who fly to the moon. Sorry, words ago. Astronauts, that's the one, because they get POTS when they come back to Earth. And I was like, joint problems, if I exercise to the point of throwing up with exhaustion, I will then injure myself trying to go to the loo because I won't be able to control my joints. I was like, that is just like recipe for disaster. There's no way I'm doing that. So being me, I said, I totally get your point. I really need to build my muscles. However, the slow and steady has been working for me so far. So what I'd like to do is carry on what I'm doing at the moment and increase my dance and then like reassess in 6 months. In 6 months, his other patient who'd tried this mad exercise regime, which is probably great if you don't have EDS or hypermobility, was actually doing worse and I was doing much better. So she'd gone downhill and I'd gone uphill. But it wasn't a problem because he was listening to me. So I was confident enough to say to him, actually no, and he was fine with me saying actually no, and then we'd reassess it and take it from there, and I won. But it's important to have that kind of relationship where your patient can tell you actually no, and then you don't necessarily believe them point blank, but you give them space to prove themselves. So, oh yeah, I took the slide down with some illustrations off my leaflet. Please read the pink and blue leaflets. They come up with it. They have some very common phrases that are used differently by the two sides, creating friction. So you've got it hurts, mean totally different things. Exercise means different things. I'd like to offer you some psychological support means totally different things. So have a read through those and you might find it really helps. And I will now shut up.